Should we? So anyway, so it's now almost 5 past, so I think we should start going. Can we just see if we've got all of the speakers? What we'll do is when it's your turn to speak, if you then ask to join the video chat, I'll let you join and then let you share the screen, and then we'll go from there. So do we have Charlotte, who's going to be first? Is she with us yet? Yes, there we go. Oh. There we go. Right. Hi, Charlotte.
Hi.
Sorry. So we've got a few. Well, we've got how many presentations? 7 presentations. They all look to be very good. I'm very excited to listen to them all. So Charlotte, if you're ready, shall we let you crack on?
Yeah.
We'll let you go, and then we'll have some questions. So our judges are Sam Mason, who we heard from earlier, and also Johnny Jeffrey, who's a orthopedic registrar in the Oxford Deanery. And then if anyone else listening to the session has any questions, if you write them in the chat, we will then ask them for you guys.
Perfect. Is that working?
So yes, absolutely. Perfect, Charlotte. I'm going to leave and then I'll join again when it's time for questions.
Perfect. So hello, everyone. My name is Charlotte Yates. I'm a core surgical trainee in the Severn Deanery. I'm talking to you today about a teaching programme that was devised by a group of core surgical trainees here called Surgical Outreach for Schools. So the motivation behind the course is that there's been a decline in the number of junior doctors pursuing a career in surgery. So for an example, the competition ratio in 2012 was 3.8 people per place. In 2017, this had fallen to 2.5. And 55% of these had also applied to other specialties alongside their core surgical application. So it's impacted the availability of hospitals to fill positions with lots of rota gaps, which has a financial cost to the NHS. There's lots of theories to explain why surgical specialty interest has fallen. Some of these are that it's still a male-dominated field, which varies according to specialty, but it can be off-putting for female junior doctors coming through. There's also a reputation for the specialty being very difficult to balance with family life, and it's a long training programme that requires high levels of commitment. So the aim of our course was to inspire secondary school students, as well as medical students, to consider a career in surgery, and through this, make little inroads to address the shortfall in recruitment. So the course itself, it was made up of 2 sessions, a theory session where we did a talk about different routes into surgery, what being a surgeon involved, a day in the life of a surgical trainee, and we did a case-based research. There's also question and answer sessions where people could address some of their concerns. This was followed up by a practical session where we covered scrubbing, gowning and gloving, knot tying, and did some laparoscopic simulation. The picture on the screen shows some of the slides that we used for the theory session. We did a questionnaire and collected data pre and post attendance to show how students' opinions of surgery had changed having attended the course. These are just some photos from the course. So the top left shows students gowning and gloving, and they're being taught by one of the medical students. The 2 middle photos show the knot tying, and then in the bottom right, we've got the laparoscopic simulation. As I mentioned, we wanted to involve both medical students and school students in our course. By medical students, the practical skills of the course, and then supervise them delivering the teaching sessions to the school students. This helped improve medical students' confidence with basic surgical skills, and they also got one-on-one feedback for their teaching, so they could use that for their course as well. So from the course, 71 students overall attended the programme, and it was taught in 8 different schools within the Southwest region. The age range was from 14 years to 18 years, and the ratio was 39 males to 32 females. From the questionnaire, we found that there was a 25% increase in students expressing an interest in surgery. All students really enjoyed the course, and 70% said that they'd be interested in further surgical teaching. From the medical student side, they all said that they had increased confidence with surgical skills, and they felt that they could gain more from their surgical placements because of this. So overall, in conclusion, the aim of our course was to inspire both school and medical students to consider a career in surgery, and through this try and address the recruitment shortfall. The response from students and teachers was overwhelmingly positive, and so we felt that we did achieve our initial goal. As I mentioned before, the introduction into the surgical field was twofold, both the school students attending the course and the medical students learning and teaching practical skills associated with surgery. So through the positive associations with surgery, addressing stereotypes and making the programme fun and interactive, we felt that we could address any concerns or barriers to surgical training earlier and hope to motivate more young people to become surgeons. Thank you very much for listening.
Great. Thank you very much, Charlotte. That was very, very interesting. We'll open up for a couple of questions. Does anyone have any questions from the audience? If you write them in the chat box, but I've got a couple of questions. So what do you think the main barriers at the moment are stopping people becoming surgeons or entering training that's putting people off?
I think almost ironically, sometimes the perceived competition ratio puts people off, or the competition levels, as well as the length of training. There's this kind of theory of like rushing to get to consultancy, wanting to settle down. And the long registrar training means that, you're commuting for a long period of time. It's very hard to settle down, especially in some of the larger deaneries. That can be really off-putting if you want to start a family. And I think the issue with women in surgery hasn't been completely resolved either. It is getting better, and less than full-time training has become much more available and less frowned upon, but there is still that perception there.
Okay, thank you. And we've got a question from Zach, who says, great initiative, but how did you select the schools?
We didn't really select the schools. It was almost we approached all schools within the region, and then schools that were interested or could accommodate us, we engaged with and went to every school that wanted us to. For future, I think we're going to further develop the course and actually have it in a more central location, and invite students to attend so that they're not limited by the availability of their school to be able to host. But yeah, we brought all the equipment and everything, but it just required then some engagement from the school.
And how many of the students actually applied for medicine?
So most of them, and it's a self-selecting population, people who'd signed up to come to this after their school, they're all interested in medicine. It was a large age range, and so at the time of year that we were doing it, some of them had already applied. And so again, I think when we repeat it for this academic year, we'll do it before applications, because then they can use it on their personal statements and interviews to show kind of engagement. But it was, so I don't have data for exactly how many, but some had already applied and everyone was interested, and just to kind of as a taster of what it would be like to be a student and then a doctor.
Great, thank you very much. It was very interesting. So what we'll do is I'm going to unshare you, and then we'll ask our next presenter, Rituja Campbell, if you could request to join. I will let you in and then there we go, perfect.
Hello, can you see me and hear me?
There we go. Yes, absolutely. So if you then share your screen, I'll then leave you to it.
Yep. I'm not great with
That's all right.
Time. Hang on, just play from start. Oh.
Yes, that's perfect. I don't know if anyone was told earlier, but if you double click on the shared screen, that will pop up big, and then you'll be able to see it in much bigger. All right, I'll let you get on, Rutuja.
Great. So hi everyone, my name is Rutuja and I'm an F2 and I was working in Brighton Sussex University Hospitals Trust. So the topic of my quality improvement project was improving confidence and knowledge amongst medical students and junior doctors at the very start of COVID-19. So as we knew at the start of COVID, there was barely any teaching available due to the issues with social distancing like it was before. So that had a big impact on the amount of, sort of formal, theoretical and practical surgical teaching that was available for our junior doctors and the medical students. And there was already an existing climate of variability when someone left medical school and the amount of surgical teaching that they had. And there was variability within the foundation teaching curriculum. And from what I knew already, junior doctors and students were reporting a lack of confidence when dealing with surgical patients as a result. So my aims were to actually make a quality improvement project to not only assess the confidence and the subjective knowledge in surgical topics amongst medical students and junior doctors, but to improve this. And I did that by trying to design a teaching program that not only sort of adhered to the social distancing ideas and the practices that we held in our trust, but to do it in a way that was accessible for everyone. So I used the PDSA method in order to sort of formally assess and evaluate each cycle. And my baseline measurements were sort of investigated by distributing an online questionnaire. This was to the junior doctors and the students in my hospital trust. And the questionnaire was essentially establishing what their baseline confidence and knowledge levels were in managing unwell surgical patients, undertaking practical procedures, and whether they even had any previous surgical teaching in various topics already. I also had a look at my trust's actual formal teaching schedule, even before COVID, to even establish if there were formal surgical teaching sessions available. So what I found at first was, so 15 individuals did answer the baseline questionnaire. As you can see from these graphs, this was how looking at their confidence in assessing an unwell surgical patient. And as you can see, that from 1 not at all confident and 5 being extremely confident, the majority were answering not very confident. And there was a similar skew in the data regarding suturing unsupervised and injecting local anaesthetic. Furthermore, I found that only 2 of the 36 formal weekly teaching sessions was actually, this was prior to COVID, was actually surgically themed. And we had none since the advent of COVID. So I designed a teaching course, myself and my team, that was trying to adhere to social distancing rules. This evolved from us actually building a face-to-face teaching session for our individuals to actually like going into an online live webinar. So this was our first teaching session, and that was essentially teaching 13 participants suturing skills and basic surgical knowledge on how to encounter a sick surgical patient if they were on call. So we had 13 participants within the teaching session, of which 25 had actually registered. However, due to our social distancing rules, that was the maximum that we could accommodate. Within this session, which 3 covered not only suturing skills on models, but we ran through step-by-step approaches on how to assess and manage initially a sick surgical patient. From our data that we collected, we had pre and post-teaching questionnaires distributed, and this was looking at their confidence levels before and after the session. And as you can see, the grey being after the practical and blue being before, there was a general increase in confidence. The mean confidence increase was about 113% actually, based on our quantitative variables that we measured. However, when we evaluated this, we found that a 3-hour session for 13 individuals was, although great, it wasn't particularly efficient in order to try and deliver the same knowledge to, a big audience, especially when almost half of the people who registered were not able to access this teaching. So we then moved on to trying to develop something that was not face-to-face, but actually an online webinar, and that actually really broadened our reach. Our second sort of teaching session was delivered to 106 attendees, which obviously was a big increase from our practical session. And this online webinar covered the similar topics, including assessing a sick surgical patient and a little bit to do with our with suturing skills. The results again showed, with blue being before the webinar and grey being after, that there was a mean confidence increase. We also measured knowledge variables by asking the same questions before and after the teaching session. And this was regarding certain questions about how to assess a sick surgical patient. And we did see an increase in our attendees actually picking the right answer. So the mean knowledge increase was around 62%. And the majority of people who answered the post-teaching questionnaire found this session to be very useful. So our conclusions that we drew from this was that, yes, it's a very challenging time during COVID-19 for training across all parts of medical school and postgraduate teaching. However, we can try and improve confidence and knowledge in surgical topics amongst students and junior doctors. And this is by implementing blended learning tools using modern techniques, such as using online webinars across an online platform to broaden our reach, not only within our trust, but outside. And this, we sort of demonstrates how this can be an effective way of delivering teaching during pandemic. Thank you. Do we have any questions?
Thank you very much. That was very, very insightful. I have a question. So, with your practical teaching session, you say you approached junior doctors and medical students beforehand, and you saw a very significant increase in their confidence in practical skills and in their confidence managing sick patients. What proportion of those 13 were medical students, and how many were junior doctors, and what kind of, and if they were medical students, where were they kind of in their medical school career?
So the proportion of medical students to junior doctors was actually, of the 13, 5 were students and the rest were junior doctors. And of those junior doctors, half of them were F1s and about a quarter of them were F2s, and we had some GP trainees there in the cohort too. Sorry, what was the other part of your question?
I was just very surprised at how significant of an increase you had with and given that a significant proportion of these people are junior doctors, I was just wondering what. Basically, I was wondering if it was going to be a stronger trend towards medical students who maybe didn't have quite as much teaching experience in surgical teaching, but it doesn't seem like that was the case with your cohort at all.
I think because, and I forgot to answer the last part of your question, the medical students were senior medical students in their final year that were there. I think this is largely in part due to the variability that people have when they are in medical school as to how much emphasis there is on surgical teaching, particularly within their final year, and how much the emphasis there is on even delivering practical teaching on suturing skills. Because even as a medical student, you do have sign-offs to do various things. However, you don't really know if that's actually done or if they get people to do it for them. So when someone does leave medical school, the confidence and the knowledge that they have with regards to surgically related topics is very variable and dependent on the student themselves. I think this is why, in part, our junior doctors also had a lack of confidence, and there was such a big confidence and knowledge increase because they come from very different medical schools, and as I said, each medical school has a different emphasis.
Thank
on
you.
teaching.
We've got a question from John Hardy, who asks, going forward, how do you think these grassroots initiatives like yours will work alongside formal courses such as basic surgical skills and CRISP?
So the formal surgical teaching things like CRISP and basic surgical skills are there mainly for those who really wish to sort of enter a career in surgery. And not only that, but they are quite expensive teaching courses. And we do need to, there are certain routes of funding, but that's not necessarily accessible for a majority of junior doctors and medical students. The course that I designed was not necessarily for those wanting to enter a career in surgery. It was, first of all, it was free, but second of all, it was actually for doctors who don't want to do surgery but need the basic knowledge in order to perform the basic skills required as a doctor when they're on call. The way that I wanted to have this alongside other courses like CRISP was actually, I've designed a website, I've designed a program that will record these webinars and make them into an open access e-module for everyone to sort of have at reach if necessary. This will actually be distributed to various trusts across the country, and it's a resource that's available, but not necessarily running parallel to the big courses like CRISP and basic surgical skills.
Thank you very much. Thank you. We'll move on to our next presenter. So James, if you want to try and join, that's it, perfect. Let me let you in.
Morning, can you hear me?
Yes, absolutely. Perfect. So if you share your screen,
will do,
and then I will let you get on with your presentation.
So is that coming up correctly, or is it?
Yes, yeah, it is. If you just then start your presentation as in, and then it should work. I think it's yeah, working exactly right.
Yeah, for some reason it's not coming up as. Are you seeing the full screen now, or is it still?
So we're still seeing it as the individual slides. Charlotte has just put a comment in saying she thinks you need to, before you start sharing the screen, if you start the presentation.
Okay, so leave. Okay.
Yeah.
Okay. better now?
That's it. Yeah, absolutely. Yeah. That's great.
Fine. All right. Morning, everyone. My name's James Dalrymple. I'm an SC3 in the UCLH rotation, Northeast London. Thank you very much for having us to speak to you today. So we're going to speak to you about a national quality improvement project that me and a team of others did over the last couple of months. So basically, it's based around this question, ST3 kind of national surgical application preferencing, we're talking about the deanery preferencing section. Is it a shot in the dark, or are trainees able to make a informed decision? So the team involved in this is me as an ST3 in trauma and orthopedics. We had Amit Chawla, who's currently a CT2 in London, and he's about to take up ST3 posts in London. And Mr. Alex Trumpeter, the Southwest Trauma and Orthopedics TPD for London. So how this kind of project came about is both through myself and Amit's experience of the ST3 application process. Obviously, it's a big period of your life, 5 or 6 years that you're committing yourself to. Where you're going to do that has significant effects both on your personal and professional life. And when we were going through the process, we found that it was quite difficult to get the kind of information that you want to know as a trainee about the different deaneries. If you're lucky enough to know someone in the deanery, you can get some personal feedback from them, but there was no kind of online resource that had it all in one, where you could go and you could find out all the ins and outs of a deanery, the structure, the type of training that they deliver, the research opportunities, the teaching opportunities. So we felt that it was difficult to make a decision on deaneries that you didn't personally know. So you potentially were missing out on a deanery that might suit you better than the one that you had selected. So that's what kind of sparked the idea in our head. So we went about creating this project. So what we did, our aims were to do like a national survey aimed at mostly kind of CT2 and ST3 level across all surgical specialties, to get feedback from them. So our primary outcome was to see if applicants felt they currently had sufficient information to enable them to make informed decisions when preferencing their deaneries. And then the secondary aims were to try to see what influences applicants, whether that was geography, feedback from other trainees, the reputation of a deanery, the size of a deanery, and then to have a kind of further understanding of how they're getting their information, and would they find an online resource containing it all useful. So in terms of how we did it, we set up a 9-question anonymous online survey using Google Forms, and this was then distributed via all the core training TPDs and the T&O TPDs via email, and also we got in touch with Boda, who were kind enough to send it out through their mailing list to their members. Results were then collated and analyzed using Google Forms software. So in terms of our results, we got 106 responses to the survey. 52% of these were kind of ST3, ST4 level, and 45% were CT2s, with a smattering of more senior doctors as well. When we're looking at what was important to trainees when they're selecting their deanery in terms of our results, what we found, which was kind of expected, is that location is what trainees find is the most important aspect of where they're going to select their deanery, followed by quality of training, then proximity to family and friends, and then followed by size of deanery, reputation, and feedback from trainees. When we were asking them about whether they thought that the current level of information was sufficient to allow them to make decisions, only 28% thought that there was, with the majority, 71%, responding that they didn't feel that there was enough information sufficient available at the moment. Then when we asked them how they're currently getting their information, it was quite interesting. So 51% get it from an online resource, 51% are also getting it from personal experience in the deanery. And like we said, that's how most people seem to get it. And then 84% also speaking to other trainees, with only 36% going to a specific deanery or local hospital website. And then when we asked them, did they think if they had more information, would that have impacted the decision that they would make or have made? And the majority thought either maybe or yes, with the minority 31% saying no. And then would they find an online resource useful? Again, the majority, 84%, agreed that they would find an online resource containing all this information to be very useful. So I think from the results there, it's quite obvious that there currently isn't enough information available to applicants in order to allow them to make informed decisions about this big decision in their training and life, and that there is currently an appetite for an online resource containing information for trainees. So as a result of that then, like I said, our QRP highlights this lack of information and that there is a appetite for an online resource. So myself and Ahmed then have said about obtaining information and creating a website called whichdeanery.com, which has now gone live last week, in which you can access information. Just at the moment, it's based on the orthopedic deaneries, but we're keen to collaborate and extend into other surgical specialties. So I think Ahmed is going to present the website in one of the expo booths during the break if people want to access that. And then there's some links here. So that is the website link, and that's our Twitter handle. If you want to get in touch with us, we'd encourage anyone from any other specialities or any of the orthopedic deaneries that we haven't currently got the information on to get in touch with us and to collaborate. So that's that. If anyone has any questions, please do shoot.
Great, thank you very much. That was very, very interesting. I just have a question. With the website itself, what information are you sort of highlighting on there? What's the core content?
Yeah, so it's based on the feedback that we got from trainees, but everything from kind of the structure of training. So it's all kind of at the moment it's specific to kind of T&O, but we basically have all information in terms of the setup of training, what sort of teaching setup is, whether they have kind of an annual presentation day, research opportunities, then where trainees will live and base themselves, and whether it's all commutable within a certain geographical area. And then just kind of like miscellaneous stuff about whether anyone has gone on to achieve kind of gold medal in their exit exams and this kind of stuff. So trying to give the kind of stuff that we wanted to know. So like when you're looking at a geographical area that you don't know, that you've never lived in before, and the deanery looks quite big, you want to know where on earth do you base yourself so that you can commute to all your hospitals. So stuff like that is what we kind of focused on.
Okay, and so we have a question from John Jeffrey.
Yeah.
So how will you ensure that website stays up to date and remains relevant year on year?
Yeah, so that's going to be a challenge. We've just obviously gone live with the first one, but I think we'll most likely we'll have a contact now from a person. So a named individual from each deanery has responded with the information, so we have their contact detail. So I think each year we'll have to get back in touch with them or a named person that they've handed the responsibility onto to make sure that everything's kept up to date. But yeah, it will be a challenge to make sure that it doesn't become obsolete in a few years.
And then we've got a question from Sam Mason as well, who asks, who should be responsible for the data curation on your website, and how do you ensure it's objective?
Yeah, so that's obviously a challenge when you're getting direct feedback from a trainee that could be biased towards their deanery. Most of the questions are quite factual based. There's not many opinion based questions, as in like, what do you think of your deanery? It's very much kind of we got FRCS pass rate off the UKITE database, and we've kept it mostly objective questions. Where do you live? Name the list of hospitals, teaching opportunities, research opportunities. So we tried to keep it as objective as possible, but there is obviously a potential for some bias to slip in. But we're trying to, with myself and Ahmed, before we upload a deanery, we'll make sure that the data looks that it's not too kind of subjective and more objectively based.
Okay, thank you very much, James.
No problem.
And we are going to kick you off, I'm sorry.
No, that's all right.
And then let's move on to Zach's presentation. So Zach, if you would like to join, there we go. Where are you, Zach? Oh, Zach, do you want to? Oh, there we go.
Got there in the end. Hang on.
Yes.
Okay. For some reason, it's not bringing up the. Just try this.
So not letting you share the screen.
No, it's not bringing up the presentation for some reason. I don't know why. Let me try and. I've got the presentation up, but it's not.
Not letting you share, or it's not letting you.
No, I've got the option to share, but then when I go to share the screen, there's no. I guess I don't know whether I can just share my. Can I share my entire screen and then?
Yeah, it should. I think you have to share your entire screen and then and do it that way. I think that's.
So I don't know whether people can. I don't know whether you can see what I'm looking at, or can you see the presentation or no?
No.
Oh, hang on 1 second. Okay. I'll just see if I can get it to work again. Sorry about this, guys.
That's all right.
No, it's still not coming up as an option, even when I'm sharing my screen, it's not.
There we go.
There we go. Right. Okay. So if I can you.
Yes. Yeah.
Can you see the you can see the presentation now? Yeah.
Yeah. Perfect.
Okay. All right. Cool. Okay. So hi. Sorry about that. So I'm Zach. I'm a course surgical trainee from the London Deanery. I'm just going to talk a little bit about socioeconomic background and how that might influence surgical training progression. So widening participation is something that the government has been interested in really for more than 10 years, but unfortunately medicine has been lagging behind other professional domains. And I've put this statistic in bold because I think it's really important. It's a little bit old now, but it demonstrates the point. So between 2009 and 2011, half of schools in the UK did not produce a single applicant to medicine. And I think that's a really amazing statistic. We also know that surgical specialties have the highest training costs. So approximately £40,000 of additional costs to reach the end of training. And we also know that those from lower socioeconomic backgrounds are less likely to enter a surgical specialty. So they're more likely to go in to something like general practice. So this is the GMC's definition of differential attainment. So the gap between attainment levels in different groups of doctors. And essentially that's how achievements may differ between individual groups. And you can decide those groups in a number of ways. So you can look at ethnicity, you can look at gender, and you can look at socioeconomic backgrounds. And it's suggested that differential attainment covers aspects of career progression. And for surgical training, one of these is the annual review of competencies progressions, which I'm sure we're all very familiar with. So what was our aim? Well, straightforward really, to investigate whether socioeconomic background was a significant factor in progression within surgical training, particularly within core surgical training. So we did this by acquiring data from the GMC for core surgical trainees nationally between 2017 and 2019, and we looked in particular at ARCP unsatisfactory outcomes. For socioeconomic background, we used the index of multiple deprivation, and essentially what this does is rank all areas in the country from the most deprived to the least deprived. You then break that down by quintiles, so quintile 1 being the most deprived, quintile 5 being the least deprived. And that's calculated using a number of variables. So they look at income deprivation, education, health deprivation, and disability, crime, and that's all factored in. And on the right-hand side here, what you can see is a map of London with the areas broken down by IMD. So the darker areas in the southwest, those are the least deprived, so the Q4 and Q5. And then in the northeast, you can see these lighter areas. These are Q1 and Q2 most deprived areas. So what did we find? Well, Interestingly, core surgical training is a significant outlier in terms of unsatisfactory ARCP outcomes, so from pretty much all other specialties except for core anaesthetics training. And when we break it down by socioeconomic background, we start to see that there's significant relationships emerging. So you can see here that if you're a Q1 or Q2 trainee, you're significantly more likely to have an unsatisfactory ARCP outcome. Now, gender and ethnicity are highly influential for differential attainment, and these are things that have been studied before. But when we start to break those areas down by socioeconomic background, we again start to see really interesting relationships emerging. So here, this is broken down by gender and socioeconomic background. So you can see that if you're a Q1 or 2 female trainee, you have a significantly higher percentage of unsatisfactory ARCP outcomes than if you're a Q3, 4 or 5 male trainee. And if you then break it down by ethnicity, again, really interesting relationships here. So if you're a BME trainee, Q1 or Q2, you have a significantly higher percentage of unsatisfactory outcomes compared to if you're a Q3, 4 or 5 white trainee. So really interesting. So the relationship between socioeconomic background and surgical training is likely to be really complex and multifactorial. And it appears to influence progression for different groups. So as we've just seen, but within gender and ethnicity, which have previously been studied as predictive factors for differential attainment, there is really interesting relationships when you break it down by socioeconomic background. Although it's not likely to be the only factor, financial resources probably contribute in some way, because as we discussed previously, surgical training is more expensive than any other specialty. And there's a clear influence both before and during surgical training. So here we're looking at purely people that are on the core surgical training program, but we know from surveying junior doctors and medical students with an interest in surgery that those from lower socioeconomic backgrounds are more likely to be put off by the high cost of surgical training. So in conclusion, there's clear evidence that differential attainment exists within core surgical training. It's really important to realise that these relationships do exist. But we need to do more work to assess the complex factors and how they interact and how they all might influence this relationship. So thank you very much. Sorry for the bit of a delay at the start, but I'll take any questions.
Thank you, Mario. Thank you very much, Zach. That was, yeah, incredibly insightful. How do you have any data of how that compares with other specialties at all?
Yes, yeah, we do. So we have data for basically all surgical specialties, and also, you know, anaesthetics, medicine, and there is relationships in lots of them, but for some reason within core surgical training, the relationship is much more significant. I don't know why that is, and the data is not really detailed enough to tell us that reason. But yeah, we do have data for other specialties where there is a relationship, and not really as significant as core training for some reason.
And do you happen to have any that data from a higher surgical training perspective at all?
Yes, yeah.
And does that follow a similar pattern as well, or?
Yeah, so we have the data for all the higher surgical specialties, so, you know, vascular, urology, plastics, whatever it might be, and there are relationships there, but they're less significant than for within core surgical training for whatever reason that might be.
Okay, thank you very much. So we've got some questions from John Jeffries again. So he says the obvious question is, what do you think we can do about this as a surgical profession?
Yeah, so I mean that's the obvious question, and it's a good one. The issue that you have is if you look at socioeconomic background, it's a predictor of attainment at every level. So your socioeconomic background affects how you do in your GCSEs, how you do in your A levels, how you do at university, and also then how you do in postgraduate exams, so MRCP, for example. So although there's maybe small things that we can do, bursaries, grants, that kind of things within surgery, really we're looking at societal imbalances, you know. So if you're going to make big changes, it's really changes that you're making on a societal level rather than just within surgery. But I think there is things that you can do in terms of reducing costs of courses, reducing costs of examinations, having more access to bursaries and things like that to help maybe people from lower socioeconomic backgrounds. Great.
We've got another question from John Hardy, who says, so in your presentation you allude to a high training cost of surgery, and now most of those costs should now be covered by sort of the core training study budget.
Yeah.
But do you think that there are additional hidden costs?
Yeah, so what I would say about the course training budget is that it's very good, and they've made a lot of progress. Particularly, I think ASIT did a lot of good work in the last 4 or 5 years to kind of make progression towards that. The issue with the current, the way the training budget works is it's a retrospective payment process, which means that, especially when you're having to book on courses that have a year waiting list, you're having to have a significant financial outlay to then be reimbursed. So you need to have the financial resource to be able to do that in the first place. And then obviously study budget doesn't cover things like, you know, if you're publishing in a journal that has a publication fee, if you want to do any additional courses, it only covers you to go to like one conference. What if you want to go to more conferences? So, you know, these are all things that affect the financial side of things. But although I think that is a significant factor, I don't know whether that won't explain that whole relationship that we've seen, essentially.
Great. Thank you very much, Zach. That was incredible. Let's move on to our next presentation. So we've got Harsha Kumar. I'll let you in.
Hello, can you hear me?
Yes, perfect. So if you want to share your screen, I will leave you to it.
Has it come up?
Not yet, but it can take a couple of moments.
Is anything coming up?
No, still don't have it. There we go. Perfect.
Is it up now?
Yes, it's up. Yeah.
It's up, yeah?
Yeah.
Okay, hi. Good morning, everyone. My name's
Sorry. It's up, but it's not maximized. So, but yeah.
Yeah, 1 minute. Yeah.
Oh, there you go. There you go.
Okay, fine.
Perfect. Thank you.
Sorry about that. Good morning, everyone. My name is Harshad Rajpal. I'm an orthopedic trainee from the West Midlands. And the study I'm presenting on behalf of a few other authors and is the UK cost studies, the impact of COVID-19 on UK surgical training, and it's a survey of 100 UK surgeons. So we know since COVID was declared a global health crisis by WHO in March, it's had a profound impact our personal lives, our social lives, our work lives, and including our surgical training. Healthcare services have been changed, they've been adapted, theatre areas have been used for recovery areas, surgeons have been redeployed, elective work has been cancelled, and non-urgent surgical procedures has also led to redeployment of the surgical workforce. This has been similar all over the world. It's been similar in the States, where surgical trainees have been helping anaesthetics. And similarly, a lot of the surgical trainees in the UK have been redeployed to medical wards to help deal with COVID-19. So there's a couple of the surgical governing bodies assure trainees that COVID-19 will not affect their yearly progress. So if they're at key points in their careers, coming up to exams, coming up to CCT, they said they will be able to proceed depending on they meet fulfill the criteria. Also, an interesting fact is the American Board of Medical Specialties, in terms of our indicative case numbers, so for example, for registrar training, you need 300 in the year. In America, they've actually reduced that by 10%, yet in the UK, we've had no kind of guidance on the number of procedures or if any of our objectives are to be adjusted. And the true impact of COVID-19, we don't really know at the moment. So the aim of our study was to assess the short-term and potential long-term effects of COVID-19 on UK surgical training. And it also provides training provision bodies and an opinion based from trainees on educational challenges we face. So this was a nationwide cross-sectional electronic survey conducted by Google Forms, focusing on the surgical educational opportunities at the hospital. It was conducted between March 20th and May 20th, so during the delay phase of the pandemic. Emails were sent out to training program directors and trainee collaboratives. The questions, we had 17 questions on our survey. We used yes/no questions, we used 5-point and 10-point Likert scales. For this presentation, I'm only going to be reporting a few of the questions as we haven't got time to go over all 17. The study was also reported in line with the Strobe criteria. All analyses were performed using R and we used appropriate statistical methods. We recorded respondent covariates, so gender, geographical location, grade, speciality, and the primary outcome of our study was to assess the impact of COVID-19 on elective and emergency training opportunities from a trainee's point of view. Secondary outcomes to be investigated were, should the COVID-19 pandemic continue, and likely we are entering a second peak, what other methods of assessment would trainees prefer or suggest, and also come up with a redeployment strategy based on surgical experience. So this was a nationwide survey, received 100 responses. 77 were male, 23 being female, with 58% were high specialist registrars, 31% were core surgical trainees. We also received responses from consultants and foundation year doctors. So here are the graphs showing responses. Received the majority of our responses from orthopedics and also the West Midlands, which is my deanery. So one of the questions was, what is the impact of COVID-19 on surgical training? It was a 10-point scale, with 0 being no impact and 10 being significant impact. And the mean score was 8.9 out of 10. There was no significant difference between surgical specialties or grades, and this answers our question that COVID-19 has had an impact on our training. In surgery, we have to also achieve certain emergency indicative numbers, certain elective operating indicative numbers. And trainees were concerned about reaching indicative surgical case numbers for emergency procedures with a mean score of 7.94 out of 10. There was no difference whether you're a senior trainee here or a junior trainee. Also, concerns around elective operating, and the mean score from our survey was at 7.26 out of 10, in terms of 10 being significant concerns and 1 being no concern. So trainees are concerned about emergency operating and elective operating indicative numbers. I think a finding of note from our study was that 94% of trainees during this time frame have performed less than 15 operative cases per month. There's a wide number of reasons due to redeployment, not elective operating be cancelled. But if this is the case and we need to reach 300 cases for the year, here there's going to be a significant shortfall from surgical trainees in achieving the indicative numbers. There were also concerns regarding WBAs and completion of WBAs, and 89% of doctors in training felt indicative surgical numbers and work-based assessment requirements should be adjusted. We've also had responses from the Royal College of Surgeons saying at the moment the indicative numbers aren't adjusted, WBA requirements aren't adjusted, however they are being taken into account at our ARCPs. Also, the more junior your surgical grade, so for example, if you're a core trainee compared to if you're a more senior trainee, is that more junior trainees felt that these should be taken into account for our ARCPs. Whereas the more senior the trainee was, for example, if they were ST7, ST8, they were less concerned. 70% of doctors thought surgical training should be extended till surgical competencies are achieved. Inevitably, training may be extended for a certain cohort of trainees, but to what duration? And this is what the trainees thought, that 75% thought should be extended till surgical competencies are achieved, rather than a block of 4 months, 6 months, or 12 months. We also asked the question if surgical trainees were happy to be redeployed to other specialties. Only 3 out of 10 surgical trainees were happy to redeploy. We also asked if, with regards to medical specialty experience, and we found that 64% of CT1 to ST6 trainees had previous medical specialty in the last 5 years. This is expected, as we expect the more senior you are, the further you are away from your medical training. So this is an important factor to consider, because now we're about to enter potentially a second peak, and it may be that we get redeployed again. But a treatment strategy, we propose for this is the more junior trainees get redeployed first, and this goes in a stepwise manner rather than whole surgical teams being redeployed. We also asked about, in the future, if we aren't able to get the operative experience, for example, in the States, in Canada, they're very heavy on cadaveric and simulation training. ST1 to ST6 trainees thought that cadaveric and simulation training was more beneficial compared to more senior trainees from ST7 to consultants. And for the senior trainees who do get redeployed, and we asked, should simulation training be used to prepare doctors for a second COVID-19 peak if they've been out of medical specialties? And we found that certain trainees thought, on the whole, that simulation training should be used for a second COVID-19 peak, and there's no significant difference between the surgical grades. So the limitations of our study, it's a relatively small sample size, we received 100 responses. The limitations are also that there are similar studies being conducted in different deaneries, and also we weren't able to gauge the exact response rates of our questionnaire. However, we know that 77% of deaneries did respond. So in conclusion, trainees have raised concerns about achieving indicative case numbers, WBAs, and redeployments. A potential strategy may be transferred to trainees to COVID-19 free hubs. And should we know from August 2021 that surgical training is changing, and should we incorporate more USA and Canada-based methods? And if we should plan for a second peak now, considering we know it's happening for surgical trainees. Thank you.
Thank you very much. So we've got a question from Johnny Jeffrey, who says, what do you think about the introduction of the outcome 10.1 and 10.2 for ARCPs?
So I think, from the West Midlands, that outcome wasn't actually given to many trainees in our region. And I'm not exactly sure. I think we need to get the statistics behind that based on how many trainees were actually given these outcomes. And now we're going to a second peak. Is this outcome going to be extended, applied to our other ARCPs, or was it just for the ARCP we just had? So I think there needs to be some clarity on it. And at the moment, based on the West Midlands, not many trainees had a 10.1 and 10.2 outcome. So I'm not sure if deaneries are actually using these outcomes how they're intended to be.
Okay. And then we've got a question from Oliver Flannery, who says, collating the feedback you received and your own opinions, what do you think we should do going forward with surgical training regarding extensions and indicative numbers?
So I think surgical training, my personal view is that surgical training should be extended till you've achieved your competencies. The issue is we're always in a rush to kind of get to your consultancy jobs or progress through training. But the reality is if we haven't had the appropriate training during these years, we may struggle, for example, when we're consultants. So I don't think indicative surgical case numbers should be changed. I think assessment methods should be adjusted. For example, at the moment, we need to achieve level 4 competencies in certain procedures. So I think assessment methods need to be adjusted, but not indicative surgical case numbers.
Okay, thank you. And we have a question from John Hardy, who says, do you think allowing surgical training to work as a NHS employee in the private sector clean sites could have positive long-term improvements in training?
So I think that's a fantastic question, and I think that is the way to go forward. We've had recent guidance saying that in the West Midlands that surgical trainees can operate in private sector, but also I suggest is that we should have COVID-free hubs where elective operating does continue, and that way we can still achieve our indicative case numbers. And I know, for example, here in our orthopaedic training, we have the Royal Orthopaedic, similar in Oxford, they have similar, in London, they have similar hospitals that can do that. So I think we should redeploy our trainees to these hubs and to these private hospitals.
Great, thank you very much. We need to move on to the next presentation now. So John, let me let you in. Hello, John.
Hi.
So if you would like to share your screen, I will let you proceed with your presentation.
Fine. Is that clear?
Yes, yeah, that's perfect.
Wonderful. So I'm John Hardy. I'm working in trauma and orthopedic surgery, and I'm also a private pilot. No conflict of interest or funding for this. So really, what I'm going to talk about is how lessons from aviation for specifically safety critical moments can really help with surgical communication. And I've been working with 3 BA captains on this over the past few months. There are quite a lot of never events and serious incidents and many other episodes that are not reported in the NHS. And ineffective communication is the biggest of all of the human factors. In aviation, specifically for those safety critical moments, there's very specific formal communication training, whereas that's not widespread within surgery. So how are they similar? Well, you'll notice that both the flight deck and the operating theatre, there were 2 pilots and there were 2 surgeons. On the flight deck, there is a captain who has overall responsibility for the safety of the flight, but there's the pilot who is flying and there's the pilot who is not flying. And that can change during the flight, whoever is operating the controls. Similarly, in surgery, there will be usually a consultant who will be in charge of an operation, but whoever is operating, it may not always be the primary surgeon. It may be the secondary surgeon, registrar, whoever that may be. So these are the safety critical moments, really, some examples of them. In aviation, takeoff, landing, entering controlled airspace or restricted airspace, or any dangerous maneuvers, high-risk maneuvers. And in surgery, I'm sure you can come up with many examples of your own as well, but inserting vascular shunts, putting in clips or implants that can't then be removed, using cement or glue, or at any points where you are controlling the head or the limbs. But also sharps injuries to the surgeon, and we've all had times where no one's quite sure who's meant to be controlling the scalpel or the sharp at the time, and people putting fingers into the surgical field and causing sharp injuries to surgeons as well. So I'm going to briefly talk about some of the principles that I've been working with these 3 captains on. This is the sterile cockpit using Reback's unambiguous phraseology and the mini brief. So the sterile cockpits, well, as pilots, when you're under 10,000 feet, there's the principle that there shouldn't be additional chatter. There shouldn't be any other sort of questions, conversations that are not to do with the safe conduct of the flight. That's a different matter. In surgery, when it comes to these safety critical moments, we can learn from that. For questions that maybe should have been asked before at the team brief, bleeps that could be given to someone else during those periods of time, and perhaps that's the moment for the music to be turned down. I mean, that's not to say that during the rest of the procedure, of course, those things aren't important and shouldn't come in, but during those particular moments, that's time to think about the sterile cockpit idea. And similarly in aviation, above 10,000 feet, that's when other chatter can happen. A little bit more relaxation can happen. Rebacks. So the main thing is having closed loop communication. In aviation, any very important information is read over the radio by air traffic control. The pilot listens to that and they transmit that and read it back to the air traffic controller, and they will either confirm that that's correct, or they will correct the pilot and say, no, this is not correct. This is what the information is, until that is correct. And again, there are certain phrases and certain pieces of information in aviation which must be read back. And if you don't read those back, you'll very quickly find that your air traffic controller will keep repeating that at you until they are happy that you've understood. Now, some of these things are already done in surgery, but that closed feedback loop doesn't necessarily happen. So, for example, implants or drugs, if they're going to be administered by the surgeon, that should be read back to the scrub nurse or to the anaesthetist. And the anaesthetist should ideally acknowledge that and say, yeah, I understand what you're about to do. Similarly, anything when there could be a physiological disturbance, such as injecting local anaesthetic, which could cause sort of anaesthetic issues. And other numbers such as a tourniquet time. If a member of team says to you, look, this is where we are, then this is something you should read back to that team member to acknowledge that they know that you know that this is an issue to be concerned about. And unambiguous terminology is very important. I mean, I could talk all day about the subtleties of this, but some examples in aviation are the air traffic control will never say the word land to a pilot until you are ready to land. Instead, they say continue approach. Whereas in surgery, it's very easy for the surgeon to say, right, okay, get ready to mix the tissue glue, or get ready to mix the cement, please. And the scrub nurse starts mixing the cement. All they heard was mix the cement. Instead, you may say unpack it to make it unambiguous. And similarly, whose operation is it? Sticking fingers or instruments into the surgical field unannounced is not always sensible because of the risk of sharps injuries. Particularly during these safety critical moments where there may be vascular issues to contend with, or something that needs doing quickly. This is time for the first surgeon to say, right, this is my operation, and for the other surgeons to go, yeah, I understand, this is your operation. And the last thing I want to talk about is the mini brief. So what are my interests in aerobatics? And certainly before you do any dangerous aerobatic maneuver, you have a quick mini brief in the air. And this is something that is in addition to your on-the-ground briefing. And this is very specific. For example, I would say that we need to start the maneuver at no lower than 2,500 feet. This is what we'll do. If we get below a certain height and we haven't recovered, we'll both jump out. And then we'll go and check that we both understand what those things are going to be in that high stress situation. And similarly, for example, putting in vascular shunts, clamps, that's something else that's a quick mini brief before that, so both surgeons understand what's happening, could be very useful. So in summary, there are quite a number of things from aviation we can really learn, and some very specific and quite simple lessons could really help with those safety critical moments.
Great, thank you very much for your presentation. My understanding is since the sort of the Lane Bromley case, anaesthetics have been quite quick to adopt influences from the aviation industry. Do you think that surgical specialties have been slower on the uptake?
Yeah, they've certainly been slower on the uptake, and there's quite a lot of emerging work being done in surgery, but there are a number of reasons I think why anaesthetics have been able to take that up earlier. I think they certainly they've had a number of people who have always been interested in patient safety from a consultant and senior point of view early on. So they've always had that ongoing interest. And the secondary thing is it's a little bit that there are closer links to other safety critical industries. They work a lot more with numbers, set parameters. There are lots. They've always worked with checklists all the way throughout their training. For example, before you intubate, they run through a quick checklist before you put in a block. You know, this stop before you block. It's all about the mini briefs. It's all about using set parameters. And certainly physiologically, your anaesthetic machine will start pinging away at you when you're outside the set parameters. So all of these things have sort of been embedded, I think, all the way through anaesthetic training. That's not necessarily, it's not quite as simple in surgery. There are a far greater number of factors that we have to deal with. We have far more members in some ways of the extended team that we need to think about as well. And that's why there's been slightly slower uptake.
Okay, and we've got a question from John Jeffries, who says, hi, John. So the comparison you make between surgical and aviation safety is not a new phenomenon. Are you suggesting the concepts you've discussed here are not currently utilised in surgery? I'm
not suggesting they're not already used. I think some of these are used to some extent, but they've never really been explicit in some ways in a lot of surgical training. And this is specifically looking at those safety critical moments where we just need to stop and think for a moment. And they're clearly aviation is not surgery and surgery is not aviation. But aviation has been a lot more advanced. And again, similar to anaesthetics, really from the beginning have thought about a lot of these human factors. And it's just something we need to make a little bit more explicit in our training. Certainly, when it comes to communication with patients in a clinical setting, that's something that is now embedded in our training. But when it comes to communication in the operating theatre, in that high stress environment, it can be left quite easily. And certainly in the aviation world, you have to pass a radio communications test and have a license to be able to use these techniques. And you can, in your simulator tests, if you are unable to think about these human factors, and if someone deems that your communication is not good enough as well as your technical skills, you can be failed for that, and you can have to retake the test essentially. So I'm not necessarily saying that we should be having additional exams. We've got enough of those, but it's something that we need to think about in safety critical moments in that high stress surgical context, to be unambiguous, to be reading back what we're doing to each other, and to really think about the sort of mini briefs and other techniques we could use in those high stress situations.
Great, thank you very much. I think it's a very interesting concept. We need to move on to our last presentation now. So John, I'm going to exit you. And then could we have Adam, our last presenter. Thank you very much, Adam. I think I just accepted you, but I may have. There we go.
There you go. Hold on. Try and chat. sorry. I'm just going to have to quit for a second. I'll be back in a moment.
That's
Sorry
right.
about that.
Not a problem at all. I'll let you back in once you. Right. I'll just reiterate. Yeah, if anyone has any questions, just type them in the chat box, and I'll happily read them out.
Right. Apologies for that delay.
Not a problem at all, Adam.
There we go. Can you see my screen fine?
Yes. Yeah. Perfect.
Brilliant. So, yeah. Okay. Right. So my name is Adam. I'm a core trainee in London, and today I'd like to talk to you about a new approach to assessment of anatomy. And this was an approach, a sort of pilot study that we developed at Imperial with a group of academics and anatomy teachers. Okay. So to give you an introduction, so why is it anatomy that we decided to think about in this way? Well, it's clearly a critical part of medical education, not just for surgeons, but also for medics. You know, in surgery, obviously we use it every day, but medics need it to be able to assess their patients as well, and all branches of medicine, really. So what's happened in terms of the teaching of anatomy? Well, clearly it has changed a lot over the years, and the change really means that it's become less faithful to in vivo clinical anatomy. So we started off with anatomy education on fresh cadavers, and then moved on to preserved cadavers. And then nowadays, in most places, we use either prosections or plastic models. And clearly that's a lot less real and true to life than fresh cadavers or human anatomy. So we do know that 3D visualization increases knowledge, motivation, and engagement when it comes to learning about anatomy. And there was a big study that they did in 2018 with nursing students. And they compared 2D anatomy education, as you can see that picture of the heart over there, versus 3D monoscopic, so that means a 3D projection that's on a 2D screen, versus 3D stereoscopic, so a 3D projection that you can walk around and that you can look at. And it showed that basically the more true to life it is, the more 3D the anatomy is, the better the knowledge attainment and the motivation and the engagement of the participants is. And then the final thing that I need to talk to you about before I can start on the project is the concept of constructive alignment. So this is something that was brought up by the educator John Biggs. And essentially it means that there needs to be alignment between teaching method, assessment, and learning outcomes, so that these activities are basically designed to help achieve the outcomes, and that the assessment is designed to enable clear judgment of whether these outcomes have been achieved. So really what we noticed is that in terms of the teaching of anatomy, there is a clear lack of alignment. So we're using 3D or cadaveric teaching methods, and then our assessment is paper-based. And then we are using this knowledge in the clinical world, where once again, it is a 3D in vivo environment. So what did we do? Well, so we used this software called, which was basically constructed by one of the members of the team. And you can see it in practice down here in the corner. And the Microsoft HoloLens augmented reality goggles. And we designed a 10-minute anatomy assessment focusing on the lower limb, where there was real-time interaction between the participant and the assessor. And the participant or the student and the assessor, they share the holographic model. So whatever the student did to that model, the assessor could see as well in real time. And here you have an example of the questions that we asked. And essentially what we tried to do is build complexity within the questions. So we started with simple recall questions, then moved on to questions about spatial relations that you could demonstrate effectively on this 3D model, and then to questions about functional anatomy and movement. And then in terms of our methodology, so we designed this on the team, and then we implemented it. So we tested it with a bunch of stakeholders who evaluated it for us, and then based on that, we redesigned the process, and then again we tested it on a bunch of medical educators, so clinical teaching fellows, and then we finalized that, and then we tested it on the students to see what their reactions are. And then in terms of how we evaluated it, so we were most interested in the acceptability and the feasibility of this assessment. Like I said, it was a pilot study, really, a proof of concept study. And then we evaluated this using a 1 to 5 Likert scale, where 1 is strongly agree and 5 is strongly disagree with the statement, and then some free text answers. And obviously we tested the feasibility during the demonstration. And here are the results from the tutors. So like I said, we tested on some tutors, and as you can see, there you can see the mean. Again, to remind you, 1 is strongly agree and 5 is strongly disagree on the standard deviation based on their responses. And the tutors all seem to enjoy it. They particularly liked, they preferred it to a 2D assessment and even cadaveric and prosections. And they particularly liked this greater understanding of 3D relationships that the model managed to provide. And then again, in terms of what they, in terms of the feasibility of it, they thought the quality was good and they didn't experience any discomfort. They were looking forward to this sort of assessment being implemented in the future, as you can see from the quotes over there. And then in terms of our students, again, they enjoyed it. Again, most of them thought that it was better than a cadaveric or a 2D assessment. And again, they highlighted this whole 3D concept of it and the ability to test spatial relations and deep anatomy on this. And in terms of the feasibility, once again, they thought that the model was adequate. Right? Some more students and tutors experienced some discomfort, as you can see, but it really wasn't overwhelming for them. So in terms of the results, we demonstrated that it's a feasible and acceptable possibility, and you can ask a variety of questions, anatomy questions, demonstrate functional anatomy, and obviously it allows, because it's a virtual environment, it allows for greater standardization in using cadavers or prosections. Now, the limitations in our study were small sample sizes, both for tutors and students, and some technical difficulties that we found. So in terms of future directions for the study, we want to refine the software and expand the anatomy coverage, so it's not just Lowland anatomy that we can test on it. And we would ideally like to step this project up to a randomized control study using undergraduates and or postgraduates, and just to give the study more power. That's my references, and thank you very much, everyone. I'm ready to answer some questions if you've got any.
Thank you very much, Adam. How do you envisage this kind of fitting in with sort of current anatomy teaching? Do you see it replacing it, or?
I think to begin with, it would have to be complementary to current anatomy teaching, but ideally, so the idea is that particularly this assessment will replace current assessments at some point. Like I mentioned at the beginning, it's to allow for greater basically integration between our teaching methods, our assessment methods, and how we use anatomy in clinical practice.
Okay, and I'll see if we've got any questions from the group. So we've got a question from Sam Mason, who says that in his experience using the HoloLens, it can be quite slow to effectively interact with the augmented reality models. And how can this be overcome or improved?
I mean, I think that's a software problem more than a hardware problem. So when we tested this assessment, there wasn't a problem with the timing, really. It was more the stability of the link in between the two HoloLenses. So there were two HoloLenses, one on the participant and one on the assessor, and sometimes that link broke. So that's the stability that we need to work on. But in terms of the timing, there was no issue with that at all. So I could see in real time exactly as the student was manipulating the 3D construct in front of me.
Okay, thank you very much. We'll just see if there's any other questions that come up, but otherwise you're our last presenter. So if not, we'll finish the session.
Great, thank you very much, everyone.
Thank you very much, Adam. There. So thank you very much, everyone, for attending the teaching and training session. I think a few of the other sessions don't finish until 1 o'clock, and then I'm sure Tom will be in contact with the rest of the program. So thank you very much.